Well, good day, everybody. This is Chris, the Ancient Scholar, and this is going to be video number 2 in a series of videos talking about corticosteroids, specifically the pre-hospital / emergency considerations surrounding the use of corticosteroids. So in the first video, we talked about how steroids are biological molecules that come from cholesterol. So you have cholesterol, and then cholesterol is modified to create steroid hormones. And then there are a variety of categories of steroids, right? There are steroids that are the sex hormones, quote unquote, such as testosterone, estriadol, estrogen, etc. And then there are what we call the corticosteroids. And the corticosteroids are steroids that come from the adrenal cortex, hence the term corticosteroid. And the main corticosteroid that is produced in the human body is something called cortisol. And cortisol actually gets hepatically, it is a pro-substance, if you will. It is actually hepatically converted into its active form, something called hydrocortisone. So cortisol is what's produced by the adrenal cortex. In the liver, it gets converted into hydrocortisone, its active form. And when we talk about corticosteroids in general, there are two major categories of biological activity. The first major category of biological activity is what we call glucocorticoid activity. And this activity revolves mainly around glucose metabolism and essentially what steroids that have, or what corticosteroids with significant glucocorticoid activity do, is they essentially make the cells resistant to insulin, hepatic cells, muscle cells, and fat cells, and they increase insulin resistance, while at the same time they also increase gluconeogenesis. And so at the end of the day, what this does is this tends to cause an increase in blood sugar because you have increased sugar production, glucose production, and decreased ability for the cells to uptake that sugar because you have induced insulin resistance. The other major biological activity is that these glucocorticoids are highly anti-inflammatory. And it is the anti-inflammatory effects that we are most concerned about because these are the primary indications for the use of corticosteroids in the emergency setting, of which I'm focusing this discussion around. And so we are primarily giving these corticosteroids to decrease inflammation of the respiratory tract and to treat people with acute asthma exacerbations, COPD exacerbations, reactive airway diseases, and other primarily respiratory disorders where there is a significant inflammatory process that we are attempting to attenuate. And so I will focus on the anti-inflammatory properties of corticosteroids in some detail. Now, the other major category of biological effects we see with corticosteroids are what we call the mineral corticoid activity. And the mineral corticoid activity of the corticosteroids revolves mainly around the retention of sodium ions, which also causes water retention. So we hold on to sodium, we hold on to water, and we tend to have a less or almost an anti-diuresis effect. In some sense, the purest mineral corticoid substance in the body is aldosterone. Aldosterone is a hormone that has almost pure very potent pure mineral corticoid activity and very little glucocorticoid activity. So think of aldosterone when you think of mineral corticoid effects. So holding on, retaining sodium, and retaining water. All right. And so when we talk about administering steroids in various types of steroids, really what it comes down to is which of these steroids have more glucocorticoid, more mineral corticoid effects, and what are we trying to accomplish by administering that steroid? Are we administering that steroid for its glucocorticoid effects or for its mineral corticoid effects? And that's primarily what is going to determine why and how we administer something. In addition to that, it is also important to understand that the corticosteroids, the various corticosteroids we can administer therapeutically, have a variety of durations of action. Some are very short acting, on the order of a few hours or so, all the way to very long acting corticosteroids, which could be many hours. And so that also does play a role in the decision-making process. And so the major side effects that we see with corticosteroid use also tend to revolve around the mineral and glucocorticoid activity, right? The fluid retention and the edema and the puffy face that we tend to see with people that are on corticosteroids chronically, particularly systemic corticosteroids, to the diabetics who have a difficult time with their blood sugars if they happen to be placed on glucocorticoids or on corticosteroids with glucocorticoid activities, right? So you see increase in blood sugar, you see sodium retention, water retention. You can have problems with hypertension in people that suffer from hypertension. And of course, you can have an increased risk of infection because the corticosteroids with glucocorticoid activity are going to be anti-inflammatory, which is going to attenuate a large portion of the innate immune system. So with that in mind, what I want to do is I do want to spend a few minutes talking about how corticosteroids impact the immune system, because again, that is primarily why we are administering corticosteroids in the pre-hospital or emergency setting. All right. So the anti-inflammatory effects of steroids. Oops. Try that again. There we go. Drop that down. And again, we're going to focus on the glucocorticoid impacts. Specifically, the anti-inflammatory effects. So what how does this happen? Well, as far as the anti-inflammatory effects go, what the glucocorticoid steroids do is, because, remember, these come from fat, right? Essentially, they come from fat. They are derived from cholesterol, so they are highly lipophilic and easily pass through the cell membrane. And once they pass through the cell membrane, they enter the nucleus of the cell, where they interact with a variety of nuclear receptors. And there are on the order of a couple hundred or so, more probably closer to 300 or so, genes that get activated and deactivated, right? The gene activity is enhanced in some cases and suppressed in other cases. And what that does is that causes these genes that would code for proteins, right? You attenuate the kinds of protein activity that is expressed by the cell when you start enhancing and inhibiting the various gene activity. And ultimately what we see is a reduction in the production of cytokines. Cytokines are a category of immunoactive molecules that essentially activate white blood cells, and specifically the interleukins, or the ILs, interleukin 1 all the way up to interleukin 8, tend to be suppressed by steroid activity. You tend to have a reduction in histamine, the reduction in the creation of histamine, which is a primary pro-inflammatory molecule, reduction in nitric oxide, which is an important vasoregulatory molecule that can allow for capillary beds to become more permeable, and then that in turn will allow white blood cells from the blood, primarily neutrophils, to leave through those permeable capillaries, and that leads to yet another effect that we see. We see a reduction in neutrophil activity. Specifically, neutrophils don't leave the vasculature. So normally when neutrophils are activated, they kind of clump to the inner surface of the blood vessels, and they, through a process of diapedesis, kind of roll along the inner surface once they clump and attach to the inner surface of the blood vessel until they can get to a little opening, squeeze out, and then go into that site of inflammation. Again, they're being activated by pro-inflammatory molecules like cytokines. And so you actually have a reduction in neutrophil activity due to what steroids are doing. And of course, because you have cytokine activity reduction, a type of cytokine are the prostaglandins, and we see a reduction in prostaglandin activity as well. And collectively, this is where the anti-inflammatory mechanism of action of the corticosteroids, the glucocorticoid component of corticosteroids, comes from. It is ultimately that steroid passing through the cell membrane, interacting with, going into the nucleus of the cell, interacting with nuclear receptors, where the activity of a couple hundred to a few hundred genes is enhanced in some cases, inhibited in other cases, and that ultimately leads to a reduction in cytokine production, cytokine activity, reduction in histamine, in nitric oxide production activity, an overall reduction in neutrophil activity, and a reduction in prostaglandin production and activity as well. So that is why we are primarily administering steroids. In addition to that, we may administer corticosteroids in the setting of somebody who has adrenal insufficiency, and that is to say that their adrenal glands are, for a variety of reasons, not able to produce and secrete cortisol, and they become cortisol deficient, such as what we see in Addison's disease, or we may see this in somebody who is on chronic systemic steroids and then ends up suddenly stopping their steroid use or withdrawing for some reason, and that can precipitate what's known as an Addison's crisis, which is a life-threatening manifestation of Addison's disease or adrenal gland suppression. And we may have to administer certain kinds of corticosteroids and able to stabilize individuals with adrenal crisis or Addison's crisis. But more commonly, we are administering corticosteroids for their glucocorticoid activity and anti-inflammatory effects to reduce inflammatory activity in and around the respiratory mucosal area in individuals with COPD exacerbations, reactive airway disease, anaphylaxis, asthma exacerbations, and so on. So hopefully that makes sense. And in the next video, what I'm going to do is I'm actually going to give you some specific examples of corticosteroids and talk about the amount of glucocorticoid versus mineralcorticoid activity these individual agents have, and talk about kind of how and where they're used, at least in the emergency setting. And hopefully it will make more sense. Like, oh, I'm using this agent because it has more glucocorticoid activity versus mineralcorticoid activity, and so on and so forth. All right, everyone. Hopefully that makes sense. Hopefully you enjoyed the video, and we'll see you in the next one.